My approach is one, reading the study, taking that information and bringing it back to my patients, but also continuing to do whatever is best for my patients, because that's really the most important thing. So let's get going as far as the DREAM study. So I think in this group, you've all heard about the study. If I was out with another group, maybe not, but we'll just go over some key points of the DREAM study. So this study is looking at high dose of fish oil or olive oil, okay, to improve dry eye disease. So this is a randomized clinical trial sponsored by the NEI. It was a well-performed study as far as many different sites. There are academic medical centers, there are individual sites, there's a combination of optometrists and ophthalmologists doing this study. The study was done over a 12-month period. 329 patients in the omega-3, 170 in the olive oil. It was purposely randomized 2-to-1 to actually, I think it was a well-designed study. Now, here's the part where I don't think, and I'm putting my opinion in here, so feel free to disagree with me, but where I don't think it was perhaps so well designed, and that is the real world conditions that patients could use whatever they were using. So that could be Restasis, it could be Xiidra, it could be warm compresses. But the one thing that really stands out to me is that they could continue fish oil supplements, so up to 1,200 milligrams of EPA and DHA. Okay, so if you haven't read the study, I encourage you to do so, but that part to me alone is really significant. So they could be taking fish oil already and be in the olive oil group, and they can continue that throughout the 12 months of the study. So the study really looked at symptoms, and symptoms were the primary endpoint, and looking for the mean change in OSDI. So there was improvement in both groups, the omega-3 group and the olive oil group, to reduce the OSDI. And there were no significant differences between the two groups looking at dry eye signs, so corneal conjunctival staining, tear breakup time, and Schirmer's. So the big question is this olive oil, okay? Is the olive oil really a true placebo, or is there something else going on? Now, key point here is that it's refined olive oil. So it's not the Mediterranean diet, super duper fancy olive oil. It's actually refined olive oil. And it's 5 grams of olive oil. So studies that are looking at the Mediterranean diet maybe look at like 60 grams of olive oil. So it's pretty much a relatively small amount, and it's refined. So, could it be components of the olive oil that contributed to the study? Well, it's a little bit of a mystery. Hard to say at this point. So it could be perhaps some components that reduce inflammation, but it's so little olive oil and so few of the components within the olive oil that it's kind of unknown if that has actually benefited. It also, looking at both groups, they improved over time. So was it a placebo effect? Was it, I'm taking these pills, the pills were formatted the same, they had the lemon essence in the two groups, in the omega and the olive oil group, to taste the same. Is it just over time, I'm taking this pill, things must improve? We don't know. But I think it all goes back to dry eye. Is dry eye one condition? I think we've talked about this over the last 2 days. Not at all. There's not one treatment modality that we're talking about. There's not one form of dry eye. Is it aqueous deficient? Is it evaporative? Do they have meibomian gland dysfunction? Do they have underlying autoimmune disease? Could it be a neurotrophic component? There's so many different aspects here. And when you're using, these two different things, an omega product and an olive oil, perhaps one group, even though it's well, designed study, perhaps one group had more of one type of dry eye and another group had more of another type of dry eye. I think the more we learn and study about dry eye, we know how complex the condition is. And I really thank all of you for being so interested in dry eye and helping our patients and helping our colleagues, because this can significantly help and improve our patients' quality of life. Now, it's also difficult to say when patients were using their traditional products, they were using all of their drops and scrubs and even taking fish oil, if that contributed to the study. So perhaps, in the olive oil group, maybe many of those patients were taking omegas. We don't know. We don't know exactly. And then one thing I'll touch on shortly is GLA that was not included in this study, which we know significantly reduces inflammation and helps dry eye. So also looking at, we all want that one number. We all want like the hemoglobin A1C of dry eye, right? I know my patients want it. Like I'm a 6.0, I'm doing great today. And that would include everything, right? Osmolarity, MMP9, corneal conjunctival staining, lid wiper epitheliopathy, meibomian gland dysfunction, including all of these things into one value. But that's not the case, right? We don't have that one number right now. So could it be that OSDI and Schirmer's are not really the most producible? I was talking at this meeting about a study, about designing a study, and I said, well, I would like to see at least speed and OSDI in the study, because you need at least a few questionnaires. The studies that I've done, it's in the past looking at dry eye and especially dry eye and Sjogren's, I find I've learned from these studies, the more information we can gather, the more beneficial that is over time. So really gathering as much as we can, I think just in general, not necessarily talking about omegas here. And the results of the DREAM study were not expected. Could it be that we're not measuring the right thing over time? Could it be the different groups that we're evaluating? Could it be something else that we just don't even know at this point in time? So perhaps we need to do another randomized clinical trial with more specific types of dry eye, breaking them up into more specific distinct groups, not including that supplemental omega that they could be taking, and having a prescribed treatment regimen, whether that be, one prescription medication or not. So these are just all thoughts I want you to take home and think about. And also, measuring the disease state initially and including compounding factors and looking over time. So my take from this study is that this has not changed my practice patterns. So my patients that are on omegas and that are doing well, I have continued on omegas. But I find this study really helps me clinically because I can talk to my patients and say, let's talk about this study and let's talk about your therapy and let's move on from there. So just one example is a clinical example is a patient who is on an omega doing quite well. This happens to be hydri, and she has Sjogren's. I have a large Sjogren's population, and these patients are so special to me. They're kind of like family because I can help them and improve their quality of life. For whatever reason, she ran out of the omega, and then she noticed that her dry eye got worse. And then when she restarted it, her dry eye got better. I had another man this week who also came in, same sort of story. His symptoms and his signs were worse off of the omegas. So I don't feel like it's right for my patients to take this study and say, well, this is what this study says, so I'm stopping you off of everything. I'm going to do whatever is best for my patients and to improve their dry eye and their quality of life. So when you talk about omegas, this is what patients see, right? They go to the store, and they're like completely overwhelmed. Oh my goodness, I don't even know what to do. So what I always like to ask my patients is to ask them where they purchased their omegas, because I find that's really helpful. If it's Costco, that's a real, red flag. It's the big bottle I got at Costco. Okay, great. We have a natural foods co-op locally, I know what they stock. If it's the natural food co-op, that's better. But I would recommend that you specifically recommend or prescribe a certain product in your practices to really increase compliance. And actually to go over how to take the product as well. Because some patients They don't read the bottle. I've actually learned this over time. They just don't read the instructions on the bottle. So going over specifically how to start that and to take it and to continue it, and also with omegas, realistic expectations. You know, most of them take some time to work. They're not going to work immediately. They're something that they do need to take long term. There are ways, of course, of reducing the dosage over time as well. So this is kind of a neat study that came out in 2015, and it's just looking at, you know, the omega-3s and the omega-6s and all the studies. There have been studies, but I think what we really learned from the DREAM study is that we have so many future potential studies that we can do to gain more knowledge about how omegas influence dry eye and how they can help our patients. So here's just a little glossary of terms, and sometimes when I talk about this, I feel like it's, you know, a tongue twister, blah, 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 blah. You know, the ALA and LA and DHA, like, we should have a competition. Yeah, let's do that. I would lose this competition saying all the terms, but I do have the terms out here for you, just for reference. So kind of moving on to the next slide here. So the reason why it's so important to recommend or prescribe a specific product for our patients is that in just regular fish oil, 20 to 30% of the fatty acids are EPA and DHA, versus highly concentrated fish oils, it's 60 to 85%. And it is important to actually read the labels and tell our patients to read the labels of how much EPA and DHA is actually present in their omega. Now, we also don't want to overdo it as well. You know, there are some, say, supplements that have omegas, and then they're taking another omega, and then they might be taking another supplement that have an omega. So I always like to advise my patients what specifically I want them on, and ideally for them to just bring in the bottle of whatever they're taking. It's amazing kind of what's out there and what my patients are finding online, you know, even. It's just, okay, well, why don't you bring that in and let's talk about it and let's talk about the specific ratios. I find that to be really helpful.
I've never been able to verify, and I don't know where I heard it first, but I was told that there are two different sort of forms of fish oil, ester base versus triglyceride. Does that sound familiar at all? Mm-hmm. And is it, you want the triglyceride, right?
Perhaps the next slides will help.
Great.
Maybe not. Okay. So here we're talking about omega fatty acids. So we have the omega-3 and we have the omega-6. And this slide might be confusing and complicated, but don't get freaked out or anything like that. You don't have to memorize it, and there will not be a test on this after. So if we're looking at the different omegas, we see that they turn into good and bad prostaglandins. So that's kind of key points here. But moving on sort of to the next slide, here we go. So ALA and LA are the most abundant omega-3 and 6s in the diet. So things like seed oil and salad oil, they're found often. However, they're not really efficiently converted to be effective. So when I like to think about this, I like to think about cars. I don't know why, I just think it's kind of fun. So when you're young and you're driving like the super fast Ferrari, right, you can just like convert really quickly, and that's great. And then when you're old and you get the Yugo, that you're like slowing down in the car, then it's converted really slowly. I don't know why that seems to resonate with my patients as well. They're like, oh yeah, you know, I understand that. Everything slows down when I'm old, ha ha ha. Yeah, that's great. So we know that ALA and LA are converted, but they're not necessarily efficiently converted, and then the conversion is based on many different things. Hormones, and I don't think we've talked a lot this weekend about hormones in dry eye, but one of my favorite ways of asking my patients is really saying, are there any hormonal changes? Because that's just a broad question. You know, have they started or stopped birth control pills? Have they started or stopped hormone replacement therapy? Are they going through menopause? So are there hormonal changes is just a really good indicator. and then oftentimes I can tie that into their ocular surface disease and dry eye. But other factors that change are alcohol, again, as Whitney mentioned in the last lecture, high cholesterol, rheumatoid arthritis. So there are many things that can influence the conversion for the omegas. So there can be a bottleneck, and so I think of that like a traffic jam, right? Car analogy here, just bear with me. You guys are all paying attention, thank you, Sunday. So there can be like a traffic jam, so they're not converted and not converted efficiently. But let's talk about GLA. Okay, so GLA is very important, and it's unique. It has a unique pathway, and black currant seed oil is a really good source for GLA. So GLA converts into good prostaglandins and converts efficiently. Flaxseed oil, not the best because it's not very efficient. And moving along here, we do want an efficient pathway, which is the GLA. It also provides ALA and LA, and it can help significantly with dry eye. So if we go back to the DREAM study, the study actually, they talked about GLA, but did not include GLA in the study design. So that's a future study I'd like to see with the size, 535 patients, looking specifically at GLA in specific types of dry eye disease that is well controlled. That's a well-controlled study. Now, the important part here about GLA is that it's a precursor to the anti-inflammatory prostaglandin PGE1, which really helps with dry eye. So there have been many studies, and I always like to share studies with my patients too. But here's just a list of all the studies. So it could be on contact lens, reducing contact lens discomfort, which I think is really important. So the way I look at I think all of you might know this by now, I look at dry eye and contact lenses, they go hand in hand. You can't do one without the other. When you're fitting even soft lenses, you have to look at the ocular surface and you have to look at dry eye. Do a lot of specialty lens work, even more so. You have to look at the surface and you have to look at dry eye. So in a study including GLA, reduces contact lens discomfort, reduces inflammation for Sjogren's, also helps in the postmenopausal women, and helps in just mild to moderate dry eye. So when your patient comes in, see exactly what they're taking, what they're using, and kind of moving on from there is quite helpful. So looking at the ratio of omega-3 and omega-6, the ideal ratio is about 4:1, okay? And the American diet is really poorly balanced, so it's about 25:1. And that causes more inflammation. Of course, we know that dry eye is inflammatory. We don't want patients to take too much omega-3s as well. We don't want them to overdo it because it can lead to bruising. Also important just to look at their systemic medications and seeing if they're on any blood thinners, aspirin, Coumadin, et cetera, because that can be additive as well. So moving on to some other nutrition aspects. One is vitamin A. Now, I'm not going to go over all of these. You have these. I put these in here for your references, for your notes, so you have this information. But vitamin A is important. And now, since it's Sunday morning, I thought I'd just throw in some fun stuff about vitamin A, because why not? So vitamin A deficiency can really cause severe dry eye. So this is not your mild to moderate at all. This is blindness. And vitamin A deficiency can lead to blindness, especially in the non-developed world. So there are multiple stories. So here's one interesting one. A report from the 1960s, a man ate bread and lime juice. Now that sounds disgusting, okay? Lime juice and bread, gross. And his eyes completely vascularized and had corneal ulcers. The next story is a woman in a cult who lived off of brown rice and tea, and her eyes melted and collapsed. This is another image of vitamin A deficiency. Another report of autistic kids that ate French fries, bacon, blueberry muffins, and Kool-Aid, again disgusting, who became vitamin A deficient. Yes, I'm throwing in my feelings about these things here. And then another report of a child who refused to eat vegetables, ate potato chips, puffed rice, and juice, and also became vitamin A deficient. So these are the extremes, right? Our patients, hopefully, are not on these diets at all. But it is important to talk to our patients about healthy diet, exercise, just like we talked to them about computer use and blinking their eyes and drinking water and taking care of their eyelids, et cetera, et cetera. I'm really finding in my younger college-age students, many of them are asking me just in general about being proactive about their eyes, what they can do, how they can help. And I'm talking to them about things like omegas and healthy diet and exercise and sleeping. It's amazing, and eating. It's absolutely amazing. The college age diet of some of my patients when I talk to them. And when they change, they get a lot of improvement, which is absolutely wonderful. How am I doing on time? I've completely lost track. Okay, great, thank you. Okay, so moving along, vitamin B. Now we're gonna just skip over that and go right into vitamin B12 because there's a study here that I think is important. So vitamin B12 is important in the metabolism of the cells in the human body. And I have the sources here just so for your reference so you can share this with your patients. But this study I thought was really interesting. So this is looking at vitamin B12 deficiency and neuropathic ocular pain. So this was a study of 90 patients, and they were divided into two groups equally, so 45 in each group, with severe dry eye and vitamin B12 deficiency. So that was the first group. So they received supplementation of vitamin B12 and artificial tears and cyclosporin, topical cyclosporin. The second group had severe dry eye and normal B12 levels, and they just got the artificial tears and the cyclosporin. So the study looked at OSDI. Specifically, they asked the third question in addition to the OSDI, have you experienced painful sore eyes during the last week? They evaluated signs like tear breakup time and Schirmer's as well, and looked over 12 weeks' time. So interestingly enough, the group 1, so that has the vitamin B12 deficiency and the severe dry eye, after 12 weeks of treatment, they improved significantly. So this study shows that you might want to test vitamin B12 in patients who have severe dry eye to determine if they have vitamin B12 deficiency, and if so, supplement them with B12. So that can help your patients with severe dry eye. And this is like a take-home thing that you can do tomorrow, right? When you see your patients with dry eye, check into the vitamin B12. Vitamin C is another important vitamin. I'm just scooting along here. I'm going to skip through some of these because let's talk about the diet that's best for dry eye. So there's so much information out there, right? Like a gluten-free diet or a paleo diet or a Whole30 diet, or what diet is best for dry eye. So when I looked in PubMed and I just typed diet and dry eye, there were 222 studies looking at the diet and dry eye. No, you don't have to read all the studies at all. But I think it's important to talk to our patients about dry eye and their diet. One of my favorite stories from many, many years ago, and this is fitting scleral lenses in a patient who has severe dry eye. He's monocular. And the problem we had 10 years ago fitting scleral lenses was the post-lens tear reservoir debris, fogging behind the lens. Huge problem. That problem is so much better now because we have newer lens designs, solutions, et cetera. So we talked about some options as far as what he can do for his ocular surface and for his dry eye. And he actually started eating oatmeal. And it helped the fogging behind his scleral lens. He also lost 10 pounds, so he was really happy about that. And he actually continues it to this day. Like, it's been 10 years, even though I've changed the lens design and all that. He has no more fogging, but it's really that changing his diet helped. This is not a study at all. This is just some experience. But I found in many of these patients, talking to them about their diet has been helpful over many years. So things I'm talking about are reducing fried foods and fatty foods, drinking water, taking breaks on the computer. But some of the just simple dietary changes of reducing the fried foods has helped the meibomian gland dysfunction and also the ocular surface, those who wear scleral lenses and even those who have not. So it is a conversation I like to have with my patients about their dietary habits. One of a recent case with a student who came in for an emergency, it turns out she ate like half a piece of cheesecake for one day. Like that's all she ate. And I asked her, is this normal? Like, is this kind of your normal diet? Oh yeah, that's kind of what I do. Okay, let's talk about that. So we talked about it. Fortunately, we have resources to help our patients talking about just normal patterns that can really help their dry eye. It's absolutely, it continues to be amazing to me. So here's one example of the dry eye diet. I'm not saying you have to prescribe this to everyone, and everyone's different, right? You could have patients who are vegan or vegetarian or pescatarian or whatever it might be, and it is important to talk to people eating all sorts of foods about their diet. Now, one kind of underlying theme is eating fruits and vegetables, increasing complex carbohydrates, eliminating alcohol and caffeine, we'll get to that in a second, reducing sugar and salt, all ways to reduce inflammation, right? So having a conversation with our patients can help them and improve their dry eye and their ocular surface over time. This is a different study. I'll highlight the key points here. It was a Japanese study done looking at diet modification, increasing physical activity, and positive thinking. So this is another take-home to do tomorrow when you're in clinic. You can talk to your patients about positive thinking to help their dry eye. Basically, the study showed an improvement over time. So lifestyle intervention can also help our patients. Now, I'm a big fan of coffee personally. How many of you are big fans of coffee this morning? Excellent. Oh, good. Oh, wonderful. So there's a lot of talk about caffeine, if it's beneficial or not for patients with dry eye. And fortunately, caffeine is good, moderate amounts of caffeine. One thing I've also found over the years is I do have some patients who only drink caffeine and coffee, only drink coffee, not water at all. So by changing that ratio, having them drink less coffee, but still some coffee, and much more water has significantly improved their ocular surface and dry eye. But caffeine does help with tear secretion, which is wonderful. Which leads to the importance of drinking water and reminding our patients to drink an adequate amount of water, keeping into account their other systemic conditions that could affect it. And then I'm just going to leave you with this final slide, and you have all these slides so you can read more up on it. But the microbiome and ocular health, I could have given the whole entire lecture and another hour on the microbiome and ocular health, but there's so much research going on right now looking into this and going into specific bacteria that are on the lids and lashes, and perhaps we will have future therapies that can be more individualized and customized based on the microbiome to help the ocular surface and also patients with dry eye. Whew, okay, so I'm going to open it up for questions. I think I just have a minute. No questions. Well, thank you for your time in this.